Good morning, everybody. Welcome to Pediatric Grand Rounds. Thanks for all of you that are here in person and all of you who are here online. Today, I have the pleasure of turning things over to Dr. Lowe, who's going to introduce our lectureship and our speaker today. So thanks very much.
Good morning, everybody. So I'm really delighted to welcome you to the 22nd annual Ronald Chard Endowed Lectureship in Pediatric Oncology. And I have to confess, this is the third one we've done, and I did not know there were slides, but Doug sent me his slides last night. And so I didn't include the Queen Elizabeth slide that were on there, but anyway. So I have to just say, let's see, if I just like this. Okay. So that was Dr. Chard, and he was an oncologist for many years here, obviously, because I've only been here for a few years. I didn't work with him, but I actually did a sub-I here, and he was actually one of my attendings. And so he was a resident fellow and physician here. He actually was vice chair for the leukemia group, for the children's cancer group before it was the COG, and he's trained 80 some odd pediatric hematology oncology fellows. And I think many of the more senior physicians in this group, not just in oncology, will really remember Dr. Chard as a consummate clinician. And Doug had put this lovely quote here from William Osler to describe how he approached medicine. So in what may be called the natural method of teaching, the student begins with the patient, continues with the patient, and ends with the patient, using books and lectures as tools, as a means to an end. So I think I just wanted to welcome you again here. I am now delighted to introduce Dr. Greg Armstrong as our Chard lecturer this year. Dr. Armstrong grew up in Alabama, as we learned last night, and trained at CHOP for both his pediatric residency, Hem-Onc fellowship, and also in neuro-oncology. He then pursued additional training at Penn in epidemiology and biostats, after which he moved to St. Jude Children's Research Hospital, joining the epidemiology and cancer control department. His career is focused on survivorship research, and he's currently the PI of the Childhood Cancer Survivor Study, otherwise known as CCSS, which has been continuously funded by the NCI, I think since 1993. He is currently the department chair now of epidemiology and cancer control. So the CCSS is a multi-institutional collaborative cohort study which has successfully established and followed a cohort of 5-year survivors of children diagnosed with cancer between 1970 and 1999 and further, and a sibling comparison cohort. This derived through 31 original participating clinical centers and has collected detailed information on cancer diagnosis and therapy received, along with health-related long-term outcomes. It's the world's largest established resource for survivorship research and has like almost 40,000 eligible participants who've contributed health-related and quality of life outcomes. Almost 500 papers have been cited over 30,000 times, and this is utilized by a group of 1,225 investigators. So this provides an incredible data set that has actually led to randomized trials leading to clinical care guidelines for cancer survivorship. So in addition to maintaining a clinical practice in both pediatric neuro-oncology and pediatric cancer survivor care, Dr. Armstrong is also a member of the Children's Oncology Group Scientific Council and the Outcomes and Survivorship Committee. And I do know that we're in for a really tremendous learning experience today. I'm going to say one other thing, which is sort of on a personal note, for people who are considering academic careers, in medicine, now that our pediatric match for subspecialty fellowships just happened yesterday. I think we were at dinner last night, and one benefit, I think, of being an academic physician, this is quality of life, this is family, is that, when you travel to give lectures, which you inevitably will do, you can actually bring your family along sometimes. And I used to do this when I was younger. I would just take one child. I couldn't take more than one because it's just too much. But it's a really important aspect of actually this, and it's a benefit, I think. You can take them, you can show them what you do, and actually, Greg brought his son, who is now touring UW, and I think it's a really special thing that we can do when we have some of the flexibility of academics. We work hard. We work on all hours. We work on the weekends. We do all kinds of stuff, but I think that's really a nice perspective.
Well, thank you, Mignon. It's really an honor to be here, honor to be invited. This is actually my first time to Seattle Children's Hospital. I've been in the city many times, been to the Hutch many, many times over the last 18 years. So this is just a tour of this beautiful place. So much has been done here. I told someone last night, I think this is the Children's Hospital west of the Mississippi that I think about when I think about academia and pediatrics, and in my field, hematology oncology. So just a true honor to be here. And I'm going to take the next 45 minutes or so and talk to you about the lifetime impact of childhood cancer and cancer therapy. And we may not get very far into this lecture, but we'll see. Okay, I'm going to keep talking. You tell me if I need to run, right? Stop, drop, and roll. We know how to do that. So here's the question I'm going to put to you through the humor, which is, can we further extend lifespan and health span? Here's the issue. 85% of children are going to survive their cancer. That is one of the wonders of modern medicine. It's one of the wonders of modern pediatrics. That means there's 500,000 survivors of childhood cancer in the United States population today. It's a growing population. It's an aging population. They have short lifespans. They survive, but they survive into a lifetime of complex chronic health problems and shortened lifespans. So we have to ask the question, can we further extend lifespan and health span? And a new problem is therapy is changing right in front of us. And all of the things we've measured with historical therapy. So we've got to now start thinking, how do we assess all of this with modern therapy? A couple of months ago, I was thumbing back through a 20-year-old document and found this figure. My predecessor, Les Robison, who's founded the Childhood Cancer Survivor Study, put this figure in a 2005 grant application where he proposed to expand the cohort. At that time, there were children diagnosed 1970 through 1986 in this cohort, and he was putting forward a petition to the NCI to say we should expand the cohort to include children diagnosed 87 through 99 because so much has changed. And here was his evidence. He showed data from SEER, comparing a population diagnosed in 1974 through 85, and that proportion surviving and how that had changed when you look at those diagnosed 86 to 97. And what changed? Well, everything. In this time period, we started risk stratifying therapy and treating high-risk patients with more intense therapies and low-risk patients with less therapy. So in this short time window, not only did survival change, but how we got there changed, which means late effects are going to change. So as I'm thinking about the modern era, I wonder, was this the golden era? Was this where all the changes happened? There are naysayers who said, Greg, not that much has changed in the last 10 or 15 or 20 years. So why would we need another expansion of a cohort to follow modern patients? So I went ahead and went into SEER and had some of my teammates replot this data in SEER, and I know this is a little bit small. This is comparing 1975 through 86 to 87, 99, essentially the same data that's here. And then followed it by plotting the advancement as we look at children diagnosed 2000 through 2020. So before I advance this slide, what do you think? Do you think the trajectories of improvement in survival are the same? Maybe not quite the same, maybe flatline, maybe no change at all? Well, here's the answer. We've continued to move the needle. We've continued to move the needle aggressively. Even in cancers like up at the top where you're looking at Hodgkin's lymphoma, where survival was already quite good, we've continued to advance cure. And so principle number one as I start this lecture is that given continued improvement in 5-year survival, evaluation of long-term effects of contemporary therapies is actually going to be essential. Let's just lay that down as principle number one. But I want to walk you through another 2 or 3 principles that I want to give to you in the front end of this lecture. Here's a second principle, and it really starts with this paper, Rethinking Success in Pediatric Oncology. We all know that our great benchmark is 5-year survival for any clinical trial. And yet Anna Lynn Williams, who was a fellow and a postdoc in our department at the time she did this paper, went into SEER and used the SEER-9 registry and looked at children diagnosed less than 20 and took a very simple mathematical calculation, excess deaths due to cancer. It's just observed deaths due to cancer in the cancer population due to minus those expected, that you would have expected from the general population. And she showed in this figure that if you look very closely, for 1985, there were just under 3,000 excess deaths due to cancer when you think about deaths in the first 5 years from the diagnosis. And that decreased by 2015 to about 2,000 excess deaths. So we did it, right? We improved 5-year survival. Of course, we lowered the number of excess deaths. But when she went on to look at deaths beyond 5 years, deaths between 5 and 10 years, and deaths after 10 years, something changed. Look at the red portion of this curve. This is a stacked plot. And you see that red portion that's increasing with time? We've pushed kids beyond the 10-year time point only to die beyond 10 years, and that number is growing. Well, partially the number is growing because there's more survivors, obviously. There's a greater number of survivors. But it's also growing because as they age into their 20s, 30s, and 40s, when they're still quite young, they're dying young. And here's the point. If you now look at 1985, there's about 3,500 excess deaths due to cancer. And by 2015, guess what? It's the same. We lost the win. We had a win and we lost it because we're not thinking about deaths beyond the 5 and 10-year time point. But when you do and when you add them in, we're not winning. So there's a long way to go. So principle number 2, well, actually, I want to show you this. It's not true for all cancers. ALL is the model. We've improved 5-year survival, but we've also given them great survivorship with low mortality rates. That's what you want. The opposite is Hodgkin's lymphoma, where we've pushed them beyond 5 years at very high rates, only to die young from breast cancer and cardiac disease due to chest radiation. And then CNS tumors is really representative of most other cancers. This is the way the other curves look. But here's the principle. Well, I'm going to actually pose 2 questions that I'm going to come back and answer. Number one, if you look at this, especially Hodgkin's lymphoma, you have to ask, what's causing this? So I'm going to circle back and answer that in a minute. More importantly, can these risks for mortality be modified? So I'll come back to that too. But here's principle number 2, pretty simple. We have a long way to go if we're going to achieve a normal lifespan in our survivors of childhood cancer. I think we can all agree on that. Now, undergirding lifespan and mortality are chronic health conditions. It's the health burden that gets them to more early mortality, right? And we've shown in CCSS, Todd Gibson showed in 2018, that if you look at our survivors diagnosed by decade, those in the 1990s have a lower cumulative incidence of chronic health conditions. So we're moving the needle. I have a lower burden, lower frequency of severe and life-threatening disease. So that's good. But honestly, take a look. It doesn't take an epidemiologist to see that's really not the tail of this slide. The tail of the slide is that none of them are close to their siblings. The gold curve are the siblings. That's our standard for comparison, what we'd call as close to the general population norm that we would expect. And none of them are close. So principle number 3 is we have a long way to go to achieve a normal health span. So lifespan, health span, we've got a long way to go. And this slide is for the naysayers, because some of you are going to say, well, yeah, okay, surely there are certain populations we don't need to study. How about ALL, right? We got rid of cranial radiation for some of them a decade or more ago. We know that cranial radiation was causing devastating late effects, so without it, this population has to be good. But I'm going to challenge that with this data from Dan Mulrooney, which was in Lancet Hematology in 2019. Now, this data comes from our St. Jude Lifetime cohort, and the population are children at St. Jude treated for ALL on our total therapy line of studies. And he looked at the total therapy studies, so those treated for ALL through total 12. All of those had cranial radiation. He compared those to all the studies since total 12 that have not had cranial radiation. And this is the cumulative burden per survivor on the y-axis. And what you can already tell is the cumulative burden of late effects is not different in the population who has not had radiation. The burden's not different. What's different is the distribution of the burden. So first of all, the light blue at the top of the first 3 bars, those are second cancers, so malignancies. So those essentially go away. There are very low rates when you take away the cranial radiation. No more meningiomas, no more high-grade gliomas as a result of the radiation. But what you flip around in the blue boxes, blue is musculoskeletal, so AVN, osteopenia, fracture, and gray is endocrine. And those endocrinopathies with cranial radiation used to be centrally mediated, but now, with the increase in steroids that were used, these are now obesity and prediabetes and diabetes, and these are life-changing. These change the trajectory for entire lifespan. So here's what I would say. The last principle I'm going to give you as we charge into this is that even among populations where we have risk stratified and reduced therapy like ALL, normal health cannot be assumed. We cannot do that. The impact of therapeutic trade-offs have to be assessed. So we've made therapeutic trade-offs. That's going to mean late effect trade-offs. So they have to be measured. They have to be assessed. So I'm going to rest my case. The prosecution has given his case that we have to assess the next generation, the current generation, the contemporary population for long-term effects. Now, I want to give you a model that we use for research, because I feel like if I can spend the rest of the time just throwing data at you, it'll feel like a blitz. But if I can put a framework and hang it on a framework that you can follow, it may help quite a bit. So here's the framework I think about. Cancer late effects research really has to begin and end with the cancer survivor themselves. And the earliest type of work we want to do is the standard epidemiologic work, identifying health-related risks, quality of life outcomes, and identifying specifically among all the survivors who are the highest risk populations. The examples would be those patients treated for Hodgkin's lymphoma with chest-directed radiation and their risk for cardiomyopathy down the road and their risk for breast cancer down the road. So that would be an example. But this is a risk, this is incidence, prevalence, this is epidemiologists thinking about observational approaches, which we do with our large cohorts. But from there, we've got to move on. We've got to understand how these are impacting survivors. What are the underlying mechanisms? Are there genetic predispositions and genetic mechanisms underlying these things? Or physiologic mechanisms that we can measure deeper, better? Ultimately, we have to translate this to some clinical impact. And so we focus in 3 areas. First is building clinical risk prediction models, the kind of individual risk prediction models that becomes a calculator that you can sit at the bedside and calculate risk with an individual patient. Clinical care guidelines like the Children's Oncology Group, long-term survivorship care guidelines, among others. And we have to develop intervention strategies that change the outcome. These have to become clinical trials, trialed for efficacy, and ultimately all of these have to be disseminated and implemented when found to be efficacious. And if we do that, then we close the circle. We come full circle with primary prevention, where we actually change how we're treating patients based on what we've learned from late effects, or secondary prevention to those already been treated. We early detection and prevention of late effects when we can. So this is the roadmap, the model. So I'm going to move us around this model and show you some examples of some of the recent research. I'm going to try to focus on work done in the last year or two so that you're really seeing the latest, the cutting edge, but I also want to talk about the future a little bit. So all of this really is based on our 2 large cohorts that we have at St. Jude. Ming Young was nice to mention the childhood cancer survivor study funded on a U-24 since 1994. I'm the principal investigator, but I stand on massive shoulders of Les Robinson, who founded this study. 38,000 eligible, 25,000 participating. And then our St. Jude Lifetime cohort, which are 10,000 survivors, 6,000 of which have been in for clinical assessment. And you might say, well, come on, why do you need 2 cohorts? Isn't one enough? And I'm going to say no, absolutely not. These cohorts are incredibly complementary in what they do and the information they provide. And when I'm talking to a lay audience, I describe CCSS as the power tool. There are so many children in this study. There are 7,000 survivors of leukemia. We have all kinds of power to look at dose-response relationships between drugs and outcomes. And I'll show you an example in a minute of a Nature Medicine paper from this past year doing just that because of the power that's in that study. But I describe St. Jude Life as the precision instrument because we're bringing all those survivors in, where in CCSS, we collect our outcomes by PROs, by self-reported surveys, to children and adult survivors of childhood cancer all over the country. Within St. Jude Life, they all come in for direct assessment. We put a stethoscope on their chest. They go through our human performance lab. They do a full Bruce protocol stress test. They go through our neurocognitive lab. They get everything you can imagine. They're the best phenotyped survivor on planet Earth. So I call that the precision instrument. So if you want to know about heart failure, in CCSS, there's a question. It says, have you been told by a doctor that you've been diagnosed with heart failure, and what age were you? So we can know yes, no, and we can put a timestamp on it and do Cox regression, time to event analysis. But if you go to St. Jude Life and ask if you have heart failure, they've come in, they've had an echo, they've had an EKG, they've had an assessment, they've had an NT-proBNP and other serum biomarkers. So which do you think is the more precise tool for making that diagnosis? It's St. Jude Life. But they're highly complementary in this way. So let's answer the death questions that we raised. What were causing those deaths among survivors, and what can we do about it? This is a paper from last year in Lancet, published by Stephanie Dixon using the CCSS. And so she looked at excess deaths, not the absolute number. This is a risk, excess deaths per 10,000 person years on the y-axis, and followed that over time and demonstrated this U-shaped curve that there's a higher risk, as you can imagine, around that 5-year time mark. But that gray area shows that these deaths are largely due to recurrence of the primary cancer. But as that wanes, you see a U-shaped curve, and then you see the risk for excess deaths going up again. This time around, it's something very different. It's something we call health-related causes, cardiac, pulmonary, subsequent cancers. You could call them treatment-related causes because they're young, and most of these are driven by the treatment they had, although some might have been just from aging. But in general, these health-related causes are largely treatment-related causes. But at any rate, at 5 to 9 years, the all-cause, when you look at all-cause deaths, the excess deaths per 10,000 was 95, and the subset of health-related causes was very small. But it flips as you get older. Deaths are largely due to treatment-related effects. And in fact, that becomes 131 excess deaths per 10,000 people. Now, what was unique about this paper is Stephanie, for the first time, drilled down to the code level of outcomes to really define what are these things. And she identified things we knew, like deaths due to subsequent malignant neoplasms. Our survivors are 9 times more likely to die young because of a cancer than the general population is to die with a cancer. And it's their second cancers, not including their primary cancer. 4 times more likely to die of heart disease, 8 times more likely of flu and pneumonia, so this is interesting. They're now an average age of, they're in their 30s, but they're 8 times more likely to die of flu and pneumonia. and 8 times more likely to die of sepsis. We have to start investigating this, right? The immunocompetence of this population is largely unknown, but this begs the question. Stroke 5 times, and kidney failure 6.8-fold. So what was sort of interesting is the causes of death are really the same as the general population, many of them. They're just accelerated. They're dying young of these things. But here was the real question. Can we do anything about it? So here's what got this paper into Lancet. Stephanie looked at the modifiable risk factors that we collect in CCSS: smoking status, alcohol use, physical activity, obesity, and underweight, came up with a score, and essentially classified all 25,000 as healthy, unhealthy, or moderately healthy based on this score, and then reran the analysis. And she saw this. Again, it doesn't take an epidemiologist to see the healthy lifestyle versus the unhealthy lifestyle have a very different mortality experience. And it gives us hope. It gives us good reason to believe that healthy lifestyle is associated with fewer excess deaths. And that gives us good reason to shoot for interventions targeting lifestyle. They should be evaluated to determine if they can reduce risk for late mortality. And you've got an expert in the room, in Eric Chow, who's doing this, leading the field in this kind of research. So an important pointing forward, I would say this decade in the cancer survivorship has been about this topic, really identifying what can we do for the 500,000 survivors that are out there. Now I want to pair it with this paper from St. Jude Life. At the same time, St. Jude Life put out a mortality paper and was able to look at several different things. They looked at modifiable risk factors too. I say they, it's we, but it's Matt Earhart. And at the bottom of the screen, the modifiable chronic health conditions that Matt looked at were a little more detailed. So dyslipidemia, hypertension, diabetes, these are things we as clinicians and physicians, if these survivors are coming into clinic, we can modify. We can improve their health in these things. So when Matt considered these, those who, so the number of modifiable chronic health conditions, the greater the number of these health conditions out of control and not under control, the higher the risk for mortality. Also, for the first time that I know of, the area deprivation index, or a measure of neighborhood level socioeconomic status, was included. And those with a high area deprivation index were 5 times more likely for early mortality. So that's both very, very important pieces of information. So the impact here is, in my mind, this is the first evidence to date that the built environment is associated with survivor lifespan. Things you know ought to be true, but we've got to show them. We've got to measure them. We've got to quantify them. We've got to know the magnitude. We've got to know the targets so that we can go after them and change the course. All right. What about new discovery? Can a cohort that's 30 years old really discover new things? When the population's 43 years old on average, can you really identify new problems, new findings? Absolutely. Let me tell you the story of anthracyclines. You know that anthracyclines are associated with cardiac disease and risk for cardiomyopathy. That's well known. But 10 years ago, Tara Henderson published a paper in JCO, the first hint or signal, as you can see from the title, breast cancer risk in childhood cancer survivors without a history of radiotherapy. So we know radiation drives the risk for breast cancer, chest-directed radiation, but an early signal that a number of women were getting breast cancer young, and they'd never had chest radiation. What in the world is going on? Is it the chemotherapy? Could they have an underlying genetic predisposition? Who knows? The Dutch, at the same time, published a very similar JCO paper with the same early signal. A couple of years later, Lenny Viega and Amy Barrington from the NCI used CCSS to take a deeper dive. They did a nested case control study of 271 women with subsequent breast cancer. And they found that the odds ratio for breast cancer increased with cumulative anthracycline dose. So the first time a dose-response relationship between anthracycline exposure and a risk for breast cancer. For every 100 milligrams per meter squared of anthracycline, an increase in risk of 23%. And then they did a stratified analysis looking at patients who did and did not have anthracyclines. And as you can see on the left, the no column, that for women who had radiation but no anthracyclines, the risk for breast cancer increases, and at 10 gray, it's 9.6-fold odds ratio. But look under the yes column, those who had radiation and anthracyclines, there's an almost additive effect. At that 10 gray dose range, the risk is almost 20-fold, a doubling of risk. So really, again, a next step in the suggestion that there must be a relationship could be a relationship between anthracyclines and risk for breast cancer. At the same time, Matt Earhart came along in St. Jude Life and said, hey, we have the genomic data on this. Let's make sure this isn't a cancer predisposition. And within St. Jude Life, he showed that the anthracycline risk for breast cancer is independent of genetic predisposition. The genes we know, the BRCA genes that we know, increase risk. So from this, the impact is that we were beginning to say that anthracycline chemotherapy increases risk for breast cancer, something we would have never known without these cohorts. Now, to close the deal, right, to make sure that we're sure, the next step was to pool data, CCSS, St. Jude Life, and 4 international cohorts. Together, 17,000 women, showed the hazard ratio was very similar, 1.24, and that above a 200 milligram per meter squared threshold of anthracyclines, that the risk is 2.5-fold increased risk for breast cancer. That matters, right? And so this was published in Nature Medicine. And so the impact here is these findings support that early initiation of breast cancer surveillance may be reasonable. It's something as we develop guidelines, we've got to now think about. We've got guidelines for chest radiation and how to screen based on that. But what about anthracyclines? It'll be something that will need to be considered in the future. So there's a lot of talk about accelerated aging in survivors. It makes sense, right? They're young, they get treated with intense therapies, radiation, chemotherapy. In theory, it makes sense, but the reality is very few people have the populations that can demonstrate this. Because to do so, you have to have longitudinal data. If you're accelerating, that inherently means you've got to look at things over time. And guess what? You have to have a comparison population, because you got to be accelerating versus something else. So that means you have to have a comparator. And so there are very few large studies with longitudinal follow-up and a comparison population, but in CCSS, we have both. So Kiri Ness led this study using a geriatric rating scale in pediatric survivors of cancer. Okay, so at point they were in their late 30s, and she looked at organ system toxicity across 14 organ systems, graded those, came up with a total score that's standard for the CIRSG, and looked at 2 time points 2 decades apart. And here's what she saw. When you stratify for females and males, the red line is the slope for change in CIRS total score over 2 decades. And then hard to see this, but the green and blue lines below are our 2 comparator groups. One is the NHANES population, and the other is our sibling population. But compared to both, the slope is clearly different. And the same is true for females if you look at the overall number of grade 4 categories. The slope for males is also different than the normative slope, but not to the same degree. And then in addition to this steeper slope, she was able to look at what's driving this. And of course, it's certain therapies that are speeding up or causing this increased burden of chronic health conditions. So cranial radiation, chest radiation, platinum dose, female sex. But for every point increase in total score on this scale, there's an increased risk for late mortality by 9%. I think that's the wow. Does it matter? Yeah, it matters. So as you accumulate this burden, even 1 point in score increases your risk for mortality. So what's the impact? That with 2 decades of longitudinal follow-up, CCSS provides evidence for accelerated burden of comorbidities consistent with an accelerated aging phenotype. All right, let's move along. Let's talk a little bit about the future, because what we've really got to think about is how do we maximally advance the field of cancer survivorship over the next 5 to 10 years. And I became department chair of the Department of Epidemiology and Cancer Control about 1.5 years ago, and that really gave me the opportunity to think about what do we want to accomplish over the next 5 and 10 years to really move the field forward. What are the areas that we've really got to think about and put our focus on? And so we came up with a 5-fold plan, and I'm going to move through a few of these for you. One, and right off the bat, is we have to develop proof of principle evidence for mechanisms of late effects for novel therapeutic exposures. As we move into the next generation of therapeutic exposures and chemotherapies and immunotherapies and targeted agents, we've got to measure them, but we also need to think deeper about mechanism. So I'm going to talk about that for a minute. To do this at an institution like St. Jude, it's going to take collaborative strategic planning, just working across multiple service lines, across basic and translational science. We should not just be epidemiologists measuring risk and risk factors. We've got to think about underlying mechanisms. That means involving our colleagues in fundamental science, and including immunology, for example. We need to do what Les left us with, this idea. Adopt the alternative philosophy. As he was retiring, he looked at us and said, hey, cohorts have got you a long way, and they will get you a long way in the future, but for this, you can't just build a big cohort. You've got to understand the underlying mechanisms and create the rationale for the next cohort. And so establishing proof of principle, starting off small and focused with deep scientific investigation, taking St. Jude Life, our deep phenotyping, and going even deeper to understand mechanism rather than building a large population. So over the next couple of years, we're tackling that. And that really starts by identifying agents that are ready for evaluation now. So lots of things are novel and new in our field, but what's really ready to study in survivors? Well, it means something has to have come to front line, to be a standard of care such that you have a number of children getting them and surviving, right? Phase 1, phase 2 agents are not ready for survivorship. We don't have enough survivors. And so there are things, anti-GD2 antibody or CAR T cells or blinatumomab. Many of these really, we should have a substantial number of survivors to evaluate. So here's one approach for neuroblastoma. We call it the legacy study, the late effects of anti-GD2 antibody in use. This is led by a number of investigators at our institution that many of you may know, including the fourth investigator is Mike Dyer. On his picture is the head of our Department of Developmental Biology. So we've got fundamental science from the very beginning on these questions. You know that this is a monoclonal antibody to GD2 specific to neuroblastoma, and since 2010 it's been a standard of care. At St. Jude, we've now looked, because we've had a frontline trial for many years, we have 60 survivors who are now at least 2 years out from anti-GD2 antibody. And the acute toxicities are well known, right? Pain, neurogenic bladder, gastroparesis, ocular abnormalities, pain, can I say it again? Right? So you've cared for these patients, you know, but the long-term effects, who knows? We don't know. We're using it as standard of care. We're putting them out into the real world. We have no idea in 10 or 20 years what this will yield. So the rationale for evaluation is this is the first opportunity to directly evaluate, deeply evaluate the risk for long-term immunocompetence, organ dysfunction, growth and impairment, pubertal timing, neurobehavioral outcomes, and the mechanistic basis for neurologic toxicity. So I love this. Our basic scientist basically spent a 3-day weekend getting so excited about this. He read everything in the literature about anti-GD2 antibody and came back and said, don't you know this binds to the myelin sheath and peripheral nerves? Why would we not think this is going to have a long-term toxicity? And we're like, yeah, thanks, awesome. That was exciting that he got excited to think about the underlying mechanism. So he said, we've got to, of course, we're going to do this in our human performance lab and look at peripheral sensory motor toxicity by function, but what about going even deeper? And so we're actually going to use nerve conduction studies and go one level deeper and assess function, a subclinical assessment of neurologic toxicity in this population. And so this study is underway, and I think our first survivors coming in the next few weeks, actually. A second study looking at CAR T cells, the CONQUER study, and I'm really proud to tell you this is now funded by a DoD grant that Amy Tallier and Melissa Hudson have worked together to secure. And this is CAR T long-term follow-up. I think they really stretched to get this abbreviation and acronym. I like it though. Quality of life and adverse reactions, right? When you've got to underline and bold and do all this, but they got it, right? CONQUER. So we know the acute toxicities. You know them well: cytokine release, ICANS, and the concern about the persistence of CAR T, hypogammaglobulinemia, future immunity. Who knows? Long-term effects? Who knows? But we've got to know. We've got to know. So this study, the AIMS, again funded by the DoD, and Nirali Shah is the fifth picture here. And don't miss the fourth picture, your own Julie Park. Thank you so much for letting us have Julie Park at St. Jude. She has done wonderful things in her time there. And I know you guys miss her, but we love her, and we're going to take good care of her. She's certainly pushing our institution in a great direction. So the aims of this study to evaluate the feasibility of conducting standardized clinical assessments in survivors after CAR T-cell therapy from multiple institutions. So these are not just St. Jude survivors. For the first time, we're opening up that St. Jude Life deep phenotyping assessment to other institutions. Nirali Shah, the fifth picture here at the NCI, runs the Carnation group of 8 or 9 institutions. So we're inviting survivors from all of those institutions for the first time to see if we can open up that tool and measure deeply the long-term assessment of CAR T and describe the prevalence of persistent toxicities and new onset late health conditions in this important population. The rationale seems pretty straightforward. First opportunity to evaluate immunocompetence, autoimmune disorders, long-term neurocognitive impact, and provide preliminary data. We should all work together on a national cohort for cellular therapy survivors. We're going to need that. These patients are absolutely going to be needed to follow for life, and we're going to need a mechanism to do that. So we should all be thinking together about this. All right, let's pick another panel. How about health disparities? It's a very important target of mine to reduce health disparities and optimize health equity for long-term survivors. St. Jude, you probably don't know the story, but in 1962, Danny Thomas came to a segregated city in the southeastern part of the United States where black kids went to black water fountains and white kids went to white water fountains. And he said, I'm going to build a hospital that will treat any kid regardless of race, color, religion, or ability to pay. He threw down the gauntlet in a segregated city, and he set a standard for care and a standard for equity. We've been about this since the beginning. This is what we do. No child has ever been charged a bill for coming to St. Jude. And we take care of a lot of those social determinants of health. And so I'm going to show you the impact of that in a minute, but there's more we can do. Now, because of time, I'm just going to hop, skip, and jump across some of this, but we're doing some really cool work. Tara Brinkman is looking at culturally adapted mobile treatment of chronic pain, things that have worked in white survivors, but then translating that by working in engaging communities into approaches that will work in underrepresented minority survivors. We're thinking about global survivorship and stigma across the globe of a cancer diagnosis and being a cancer survivor across the globe. I'll skip some of our recent publications for time, but I want to show you this. Kiri Ness has a paper under review looking at the evaluation of racial and ethnic disparities in 5-year survivors at St. Jude, and I'm really proud to tell you that despite what you see in SEER or any national database where there are clear disparities, where white children have greater 5-year survival than black or any other race or ethnicity group, at St. Jude, there's no difference in survival rates between non-Hispanic black and non-Hispanic white children across all cancers. But Hispanic children still have a higher rate for for mortality at the 5-year time point, a relative risk of 1.43, even after accounting for insurance status and social deprivation index. Even though we're flying them in, paying for everything, what happens is, at the end of all that, they go back to their home. They go back into their environment. And so there's still so much to do from a survivorship standpoint in thinking about health equity. So, an exciting area. Let's keep moving around the model. Let's dive into genetics and underlying physiologic mechanisms. We've got to go deeper as we understand survivors. So, just show you a few examples. This was published last year in Lancet Oncology by Xiaoming Wang in our department. He now is answering the question we've never answered. We've looked at all these second cancers and deaths from second cancers, and we've always said it's all treatment. But we've always known there's some of these kids with underlying genetic predispositions for cancer, that it's not the treatment, it's the genetic predisposition. So he solved this. He looked at 12,000 survivors in both of our cohorts, all of whom have whole exome or whole genome sequencing. And he saw that when you look at cancer predisposition variants, the rate was 6% in the population. And those that had it had a 3.5-fold greater risk for mortality due to second cancer in both cohorts. So clearly, that's a subpopulation that we've got to start thinking about and potentially screening for, because genetic counseling, testing, personalizing cancer surveillance will be needed for this small but important population at high risk for mortality. Another important paper over the last couple of years was in Nature Medicine by Yadov Sepkoda in our department. And there's a lot of investigations into genetic predisposition for late effects, but this is a winner. He looked at morbid obesity, and he looked at the genetic risk scores from general populations. There's well-established genetic risk scores associated with obesity in the general population. What about if you apply those to survivors, in addition to the cranial radiation and the steroids and the other risk factors for obesity? Does it matter? Or do those treatment factors just obliterate the risk from genetics? What he showed is when you look at a genetic risk score of common variants associated with a 53-fold increased odds of morbid obesity, yeah, that matters. I don't have any other odds ratio in this slideshow or anything I think I've ever done that's that high. And so what this tells you is, in addition to the therapies that drive obesity in our population, we probably can't talk about obesity anymore without thinking about the genetics, without considering this as an essential covariate. So it becomes very important. I think we'll discover other things like this, but the magnitude of this is high. And of course, that improves the AUC and improves our risk prediction. So the time is going to have to come where we move genetic screening into clinic. And we have the survivorship chip that we run when they come into survivorship clinic with a few of these risk factors that are driving risk that we can then segregate the population into high risk based on genetic outcomes. But that's a future to become. We'd call that precision survivorship, right? That would be precision survivorship. So let me talk a minute about precision survivorship. We're already doing it. And I'll tell you who has been leading in this, and it's been Eric Chow. These are actually an old set of slides, so I have to apologize. I put Eric's picture on the slide, and I'm so sorry that it's not there. So I know. This is one version short of Eric Chow version. So this is an example. If you go to the CCSO website, you can look at our breast cancer probability calculator. You start inputting known risk factors while you're sitting there in the room with your patient, and you can give them a risk for breast cancer over the next 20 years. But we have calculators across all kinds of outcomes that have all been developed in the last 5 years, 5 to 7 years. Breast cancer, heart failure, kidney failure, but Eric has absolutely led this charge as chronic disease working group chair for CCSS, and then through his own work in heart failure, stroke, and myocardial infarction. These publications have all been high-impact publications, and there's been 10,000 hits to this part of our website because people are using them. And when I went to my program officer this week at the NCI to make the pitch for a cohort expansion, and I showed this slide, I wanted to emphasize that they're being used by clinicians, and she said, I know. When I send a survivor to a cardiac evaluation, the echo comes back with Eric's risk score calculated at the bottom. So the cardiologist is reading the echo and then taking all the other risk factors and using Eric's calculation and putting that onto the report. So congratulations, this is being used, and hopefully changing care too. But precision survivorship care, and I'm going to have to move fast. We're going to leverage St. Jude Life because of that deep phenotyping. We can do things in St. Jude Life, the longitudinal assessment, but the direct and deep assessment, sequencing of every patient. And I'm using cardiomyopathy as the example. Here's what Eric and we at CCSS have done, and this is what you get if you go to the website. Anthracycline dose, chest radiation, young age, female sex, known risk factors, input them, and you get a risk. But we've got to now fast forward and add things. So what about genetic predisposition? What about cardiovascular risk factors? Well, Eric has done that in CCSS. But what about things you measure in clinic, like echocardiograms with longitudinal strain? Should we use that or not? What about NT-proBNP? Should we use that or not? We don't know. But we've got to move towards precision survivorship by using these things you're measuring and understanding if they increase risk. So Matt Earhart has taken a really nice step with those last two factors, physiologic biomarkers associated with cardiomyopathy. And his aim in this study was to leverage serum and echo-based biomarkers to identify associations with future cardiomyopathy. So you've got a kid in your clinic, they look great, they don't have heart failure, they don't have heart failure symptoms, and their ejection fraction is normal. Looks great, send them home, right? But what if you did the global longitudinal strain and the NT-proBNP and they're not normal, or some combination of not normal? Well, you can see in the red text, abnormal global longitudinal strain and an abnormal NT-proBNP in that setting of a normal ejection fraction in a kid with no heart failure who looks great means that their 5-year risk is fourfold for developing cardiomyopathy. So yeah, we probably should be. This needs to be validated, it needs to be replicated in another population somewhere. We need to progress it down the lane the right way, but it's beginning to show that we really need to move towards precision survivorship. So precision survivorship for early identification of high-risk populations is feasible. We should be doing it. Other things to think about. What about biomarkers of age acceleration? What if we went and measured age acceleration in an underlying biomarker sort of fashion? And so Xiaoming Wang has done a lot of that work looking at telomere length, epigenetic age acceleration, clonal hematopoiesis, and now has an R01 doing this very thing, looking at age acceleration longitudinally in St. Jude Life. Could that predict or identify the subset of survivors at highest risk? I'd love to read through this in great detail, but I'm going to be way over time if I do. Clonal hematopoiesis, lots of great work here too in survivorship, but I'm going to, for the sake of time, skip over it. So here's what we're doing. We're now committed to longitudinal methylation profile. We've done methylation profiling in all 6,000 St. Jude Life survivors at baseline, and now as they come in for visit 2 and visit 3, we're doing longitudinal methylation profiling because this epigenetic aging and methylation, specific methylation patterns may really give us a clue to who's at risk and what's driving risk, and to underlying mechanisms driving risk. Proteomics may give us a clue. So we've got some novel work by Yadov Sepkoda looking at proteomic profiling and identifying 27 proteins in a small pilot study that identify a population with cardiomyopathy. This is now an R01 that he got 11th percentile score. If the darned NCI would not keep lowering their funding lines, we'd get this funded. But someday I think we will. So the impact here is results support an untargeted approach to identify novel predictive markers in this population. So moving the field forward as far as genetics and genetic predisposition.
Plenty of time. We have 15 more minutes.
Oh yeah, but you don't know how many slides I have.
Okay.
So here's the punchline. Here's what we should be doing in precision survivorship, right? Precision survivor care, first of all. Risk-based follow-up. We should use these tools to decide when does someone need to come back? 1 year, 5 years, 5 months? This data should tell us. Number 2, precision prevention intervention trials. These underlying biologic mechanisms should help us select populations and target populations for interventions. And primary prevention, some of the genomics and genetics discovery really ought to drive who gets selected for certain types of therapies. So potential for impact here is establishing intermediate outcomes, biomarkers, genomics, and multi-omic markers for advanced precision survivorship. All right, moving on to clinical care guidelines. This is not my area of expertise, I'll just tell you, but I've been impacted by this circle diagram because I've been doing this for 18 years, and I've got 400 publications, and I don't care about the next 10 years and getting another 100 publications. I just don't, because I'm worried we're not going to close the circle. I'm worried we're not going to get this data back to survivors and change care, and that's what matters. So part of our effort now is to implement guideline-based care to all survivors. And here's the problem. We have guidelines, but after 20 years of guidelines, current guidelines have had limited impact in community settings due to poor uptake by practitioners and survivors. So we have guidelines, but no one's using them. That can't be. That's got to change, right? And so here's the data that shows this is the case. Look at colorectal screening. In 2003 in CCSS, less than 20% of those at risk for colon cancer due to radiation are getting the screening. And, we didn't change the needle that much by 2016. It's still 40%. And the same is true for cardiac screening. Not even half those at high risk for cardiac disease are getting screening. So we've got to do better. So we're committed to leveraging implementation science, doing stakeholder acceptability evaluations and to adherence, and we're doing all of this now. We're actually working with an external consultant to move faster on this. We're looking at talking to survivors, oncologists, and general practitioners. We really want to develop a limited set of high-yield, high-risk, high-yield guidelines that can be disseminated in a proper way. We're working closely with implementation scientists at Washington University in St. Louis and our global pediatric medicine department, and we're leveraging one of their platforms, the ARIA platform, developed to implement clinical trials across the world. Because if you go to Uganda to treat someone with ALL, you don't have all the tools you have here. How do you target in lower income settings? How do you treat that patient? So ARIA creates a way of looking at your resources and doing resource-guided treatment across the globe. Guess what? We can do that with survivorship. We can put guidelines on ARIA, and in different resources and different settings, begin to now look at the world and say, here's what you do for survivorship in an upper middle income country as opposed to our country. So the potential for impact is worldwide guideline-based care to all survivors. So we're moving around the circle. Do we do interventions? We do. For the sake of time, I'm just going to mention that we've actually moved interventions. Where do you really want to intervene? When they're 30 and 40 years old? Or right after therapy, or during therapy. So this is a really nifty study that is under review right now, and I'll spare you a lot of the findings, but Carrie Ness went to children diagnosed with medulloblastoma who've had their surgery and now they're in radiation. So they get their 6-week period of radiation. Can you exercise them and put them through rehabilitation at that point? We didn't know. But it ends up you can. So this study was highly feasible and actually improved peak oxygen uptake in this population. It really sets the tone for early interventions to remediate some of the problems from a very early age. So cancer control interventions for children at the time of therapy are feasible and need to be targeted. And so we're doing that across a series of studies. Here's an intervention I think is really important. It's called Health Share. This is Ai-Chan Wang and Yutaka Yasui with an R1 with the overarching goal of utilizing daily monitoring of symptoms to monitor activity and improve survivor care. Guess what? How often do you see your 5+ year survivors? Once a year. And then they're off into the real world, off into adult care, off into community settings. But what if we had an early warning system for disaster? What if through monitoring their symptoms or through monitoring through wearable technology their physical function and activity, we had an early warning system? And that's essentially what this grant is doing, is using these tools to see if there's a combination of them that become the early warning system for survivors who are out there in the real world. So the impact is an early warning system. I guess I said that. Here's another intervention, moving again to a totally different population. This is an insomnia intervention, but not just to improve insomnia, to do aim 2, which is improving cognitive function. So using a standard cognitive behavioral therapy that's effective in the general population called shut-eye, and deploying it in our survivors. So Kevin Kroll and Tara Brinkman are doing that. And my Eric Chow slide is not here. because this is Eric has the salsa study following on the chip study. So chip and salsa together, targeting exercise and yes, diet. Seems a little shady, but the reality is Eric is moving the needle on how to go out to populations that are not here at your institution, but are across the country in CCSS and intervene on them remotely with remote strategies that could change the health course in our key outcomes that I've showed you all through this slideshow, cardiac outcomes and obesity. So you've got the world leader right here among you. And then I'm going to close with this slide. I should tell you a little bit about some of the things I do personally. And so this is the last intervention trial I'm going to mention. We're actually intervening on some of these underlying biomarkers, and in this case, cellular senescence. So Jim Kirkland was the chair of geriatrics at Mayo until a few months ago. He just moved to Cedars-Sinai. And this was a fun grant to write. You had a geriatrician and a pediatrician writing a grant together. And we based this on his underlying laboratory work on cellular senescence, the idea that senescent cells put off a cytokine milieu that drive aging, and that's now well known and established. And the fact that children who receive radiation and certain chemotherapies have greater burden of senescent cells. So it stands to reason that cellular senescence could be a driver of accelerated aging. So the other thing Jim has done is targeted senescent cells with senolytic agents. And so this is a randomized first-in-survivor trial of two combinations of senolytic agents, fisetin versus dasatinib and quercetin. And so we're targeting 60 individuals that have a very extreme phenotype. They are physiologically frail, having 2 of 5 Fried criteria, so they meet the frailty criteria, and they're including slow walking speed. And so our two endpoints here are P16-ING4A, the biologic marker for senescence. Can we move the needle and eliminate senescent cells? And walking speed. At the end of this trial, do we see any physiologic response? So we are now in the last year of accrual, hope to accrue and finish accrual by the end of 2025 and see where this gets us. So I think this is how we advance the field over the next few years, thinking about novel therapies and deeper mechanisms, guideline-based care for all survivors, realizing precision survivorship, thinking and moving the needle on health disparities, and expanding our most important resources, our cohorts. We will need to expand those to capture the next generation of survivor. So with that, we've gone full circle, and I've done it on time, I'm probably happy to say, despite the odds. And then I always like to close with this slide. This is really team science. People talk about team science. You can't read these names because I had to use a font so small because the names are so many. But this is who works on CCSS, St. Jude Life. These are the leaders from across the globe, across the country, plus everyone in our coordinating center at the 5 cohorts, core sites, including Fred Hutchison here, our 31 institutions, which includes this institution. So it's just a massive thank you to all of you and to a very big team. And with that, I'm happy to take questions if there's time.
Thank you for an incredible talk and for all of the work that you do to have such an incredible resource for investigators around the world. It's really life-changing. As somebody who lives in this space a little bit, I'm curious how you frame interventions that are lifestyle interventions or behavioral interventions that, for decades and decades have had incredible effect sizes in terms of how they're able to actually move the needle, as you say, in clinical outcomes, but don't often get the same kind of investment as, let's say, therapeutic interventions. And so how you really sort of market when you can't commercialize an exercise intervention in the same way that you can a pill.
Well, we made a real mistake. One of the first interventions we did in CCSS was led by Melissa Hudson. It was called ECHOES. And the intervention was essentially a nurse practitioner, an APP, advanced practice provider-driven intervention. And it was highly successful. It doubled the rate of cardiomyopathy screening. But it could never be implemented. You could never go to 500,000 survivors and have enough advanced practice providers to do an intervention. And we didn't think about that. This was before implementation science really began to burgeon and grow. And so that was real mistake number one. So from the beginning, thinking about what is really going to be disseminable, so again, using mobile health or other technologies that you can quickly turn. So that's essential. And then the appeal, honestly, stand on the Lancet paper. Stand on that paper when you appeal to whatever grant funder you're saying is that this matters. This could change the life course for these survivors. There's a fair amount of data there that I think you can stand on to say this matters, this changed trajectory. So it is difficult though. And again, with additional NCI cuts lately, it's getting more difficult. So. Eric actually may have input on that. Do you have anything you'd want to tag along? Because he's done it very well. So, how do you get this done?
New experience to have to answer questions during grand rounds on the audience, I guess. That's a good trick. I'll have to remember that next time. Yeah, I mean, that in some ways is a lot of what we do in survivorship or supportive care is, at least in the U.S. healthcare setting in general, outside of certain systems like Kaiser, we're not incentivized to focus on prevention as much as kind of treating complications with expensive medicines, right? So I think it goes beyond just pediatric oncology, but it reflects a cultural or systemic issue, at least in our healthcare system.
One other point I'd add is show me in the general population interventions that are having the magnitude effect of the ones we've seen. So ECHO's doubled the risk of screening. Show me an intervention that does that in the general population. We just did a screening, an intervention called the ASK trial that led by individuals out of Harvard. It was published in JCO 2 years ago. It doubled the rate of skin cancer screening in this population. Where do you do that in the general population? So the magnitudes of effects of these interventions are large. We're still not hitting quite 50% of being screened, so there's still a problem. But the magnitude effect is really bigger than what you see in many general population trials.
Thanks. A couple questions and comments from online participants. From Jared Roach, great lecture and very important data and insights. In the multi-year comparisons of number of excess deaths, would it be appropriate to report % of excess deaths?
I'm not sure I understand the question. What is it?
Jared, if you want to write and clarify, that would be great. In the meantime, I'll go to another comment from Susan Marshall. Dr. Armstrong, thank you for an absolutely inspirational grand rounds and a wonderful tribute to the legacy of the extraordinary Dr. Chard. Thank you so much. I'll give him a chance to write some more as fast as he can.
That's okay. I'm happy to answer later, too.
Okay,
So.
thanks. Yeah, we can get you later. Do you want to just say goodbye to everybody?
Oh. I'm like, what was the question? No, great. That was phenomenal. Thank you. It's always so amazing to hear what's going on with both the CCS and St. Jude Life. And I love that whole ability of St. Jude, who advertises everywhere in every city for a little money from all of us. Yeah. But I mean that it's going to such amazing research. So thank you so much. So one more round of applause.
Well, thank you so much for the chance to be here. Thank you.